Well, good morning, everybody. We got a treat this morning. Anu Amin, our partner, is going to give us a talk about metastatic spine tumors, an important subject, as he built a fabulous practice here and has grown an amazing service with the help of his spine colleagues. By way of background, Anu went to undergraduate school at NYU. He's a true New Yorker. He earned a Presidential Honor Scholarship. It was a total academic scholarship to go to that very expensive school at NYU, and he made the Dean's List and Phi Beta Kappa. After that, he was selected for Hopkins. That's where he went to medical school, where he met his wife, Trang, also a physician from Hopkins. And then he went off to neurosurgical residency at Medical College of New York in Valhalla, New York. And then his spine oncology fellowship to Memorial Sloan Kettering of a very well known and excellent spine fellowship. He's produced over 40 peer reviewed publications, multiple book chapters, and he is the associate program director at Northwest Hospital. And without taking any more of your time, Anu, tell us about an update on metastatic spine tumors. Thanks for giving the talk.
So good morning, everyone. Thank you for the introduction, Dr. Elwood, and the opportunity to speak. So just wanted to give this updated talk. Some of the senior residents may have seen similar slides many years ago when I first got here, and just some more updates and I think a reiteration of what to think about for these patients that are pretty complex that we see on a daily basis, especially as we get the new residents and I think the new interns who are starting perhaps today.
The new interns are here. They have been
Awesome.
working for a few days, I think for several days now.
Awesome. So let's see. Okay, disclosures, and then the objectives for today's talk is to discuss the NOMS decision framework for managing metastatic spine tumor patients, which will be mostly focusing on describing the spinal cord compression scale and discuss how that's related to treatment planning and discuss the SINS scoring system and its role in determining when to stabilize a spine fracture. And then we'll go over some case examples and some studies that were discussed in here. We'll be the Patchel trial, Cafe trial, and then just a couple more of internal data for our own research that we're doing at the end if we have time. So as we all know, with metastatic spine tumors, they're becoming more and more prevalent. Perhaps more than greater than 20% of cancer patients will eventually develop a spine metastasis. We think this increasing number is happening because number one, we have better detection with more prevalence of MRI scans and patients getting more surveillance PET scans, but also because patients are having improved survival with better systemic options such as biological targeted therapies and checkpoint inhibitors. And some of these large molecule that are used for compounds that are used for targeted therapies, they have difficulty sometimes getting distributed nicely into the bone. So we're seeing a lot of these patients have good systemic control disease, but perhaps their tumor will kind of escape those targeted therapies in the bone and possibly the brain because they have difficulty getting across the blood-brain barrier as well. And then also we have had a lot of advances in radiation. We'll go more into SBRT, stereotactic body radiotherapy, which has been shown to improve survival as well. So we're just getting these cancer patients that are surviving longer as their therapies are becoming more and more advanced. And so then we're seeing the late downstream effects of that, which is more spinal metastasis and brain metastasis. And so in terms of the goals of spine surgery and management is really palliative at this point because of their metastatic state. So the goals are really to focus on the quality of life and improving that by having better pain control, preserving their neurological function, providing some local tumor control, and then stabilizing the spine if there's a fracture or instability. And so will involve a multidisciplinary treatment approach involving the systemic treatments, the radiation, which we discussed, and obviously for us, the surgeries, which can be a whole gamut of options nowadays, from things that are minimally invasive, like percutaneous cement augmentation, also known as kyphoplasty or vertebroplasty, as well as our bread and butter for our open surgeries, which is separation surgery, which we'll go more into detail. And then there's more caveats of, how big of a surgery do you need to do on block versus intralesional. We'll go into some of that debate here. And so this really multi-tiered approach kind of highlights the fact that management of this cannot be in a silo, and we really need to kind of build a village and build partnership with our oncology colleagues and radiation oncology colleagues here to provide like sort of the best care we can for these patients. And so, in terms of when we have all these various treatment options, how do we sort of think of these patients when they present to the ER or to the clinic, so we can provide the best care? And so, for these incredibly complicated patients, these are the four fundamental assessments that we typically make. And this is incorporated into this decision framework called NOMS. This was developed by my fellowship director, Dr. Bilski at Sloan Kettering. And so this is what we would go through for every single patient consult that we saw. So we're really looking at, the neurological condition of the patient. Are they presenting with any symptoms of cord compression? That would be defined by radiographic evidence. But then obviously there's symptoms as well. Do they have any myelopathy or radiculopathy? And then oncological assessment. What type of tumor do they have? We need to become basically oncology surgeons. Do you need to understand different tumors are going to, histologies are going to respond to radiation differently, and that's going to affect the surgery that we opt for. And then for as specifically for unique to the spine is going to be the mechanical component. Does their spine tumor lead to a fracture? Is there a difficulty with withstanding the normal biomechanical loads that the spine is supposed to handle? If so, that's going to require surgery. And this is often missed by our colleagues in medical oncology and radiation oncology, as they may not have a lot of experience of how to manage a spine fracture and when something should be worrisome and when to get us involved. And then finally, we need to incorporate all these different assessments with the systemic conditions of the patient. What's their extent of their metastatic tumor burden? What's their predicted survival? What are their other medical comorbidities? And obviously, this can be a moving target and can really complicate our surgical plans. And so when you sort of combine all these different assessments, yeah, it can get very complicated here where you're looking at, do they have different degrees of cord compression? Is it a radiosensitive lesion? Are they considered stable? And can they even handle surgery? And so you get all these sort of arrows going to various parts of the screen here, which can be complicated. So I'm hoping to kind of break that down into how I sort of view this for all of our patients. And this would be really helpful for our residents when they're trying to make a decision on when we need to intervene or not on any of the ER consults that come in. And so again, we'll just kind of go down for each of these four pillars, how we kind of think about them. So starting with the N for neurologic, we're looking really at the MRI in addition to the clinical exam. So we're looking at what's their degree of cord compression. And this is also known as sometimes the Bilski score or epidural spinal cord compression score. And so for low grades, we're talking about grade 0 and 1. And 0 would be where there's bone only disease. Whereas 1 is that it's sort of escaping the bone, starting to enter the epidural space. I would consider both of these low grade, and these are cases where radiation may be suitable without an intervention if the exam is appropriate. And then for the higher grades, well, these are grade 2s and grade 3s. Grade 2 is when the tumor extends into epidural space and is compressing the spinal cord, but there usually still is spinal fluid that's surrounding the cord and that's still present. And then grade 3 would be essentially you have circumferential disease, high grade cord compression. There's no obvious CSF leak. You can imagine, this is going to be a grading tier that's continuous, and a patient may continue to proceed along this tract if we don't intervene early enough. So very often in the ER, we're seeing patients in sort of these grades 2, grades 3 when they become much more symptomatic from their cord compression. And then we're also, when we're talking about the oncology component, we're talking about how sensitive is their primary tumor histology through radiation. And so we typically think of this as breaking it down into certain tumors that are radiosensitive. So here we see a lot of patients with blood-based disorders such as multiple myeloma. And so multiple myeloma, lymphoma, these are all considered very radiosensitive. And then in the intermediate category, you have some solid tumors like breast cancer and prostate cancer. And then for the majority of these radio-resistant tumors, we're talking about solid organ tumors such as colorectal, non-small cell lung cancer, kidney, renal cell, and melanoma. And the difference in conventional radiation is huge between these two categories. So with conventional radiation, and when you are delivering conventional radiation to these sort of radiosensitive ones, we get a median response of almost 11 months and a 2-year local control rate of 86%. And this is in stark contrast to our patients that have radio-resistant tumors, where conventional radiation will really only provide response for 3 months, and the 2-year local control rate drops down to 30%. And so this is where it's super important to know if we're dealing with a radio-resistant histology, because this is going to require something, an alternative radiation plan rather than just conventional. And that's where we'll start going into the stereotactic radiosurgery. Um, we'll get back to that in a couple slides. And so then when we're looking at the M for mechanical, we're looking at what can they handle the physiological loads from their tumor. And so we have this scale here called the Spinal Instability Neoplastic Score. And most of these are determined based off of a CAT scan and MRI, which we're going to have in the ER. And then the only component that's clinical is the pain category. So we're looking at the location of the tumor. And basically, it's a very simple point system that, if you have something at the junction, so occipital cervical junction, cervical thoracic, thoracolumbar, you're going to give a higher point. That's more concerning for instability. Is there pain just constant throughout the day or throughout the night? Or is it really associated with movement, like bending, twisting? They're having a hard time sleeping. That's going to give you more points there. If you have a tumor that's blastic, they may actually have a lot of sclerosis on a CAT scan, and that would not be considered unstable. Whereas a lot of our patients do have lytic big defects that would be considered unstable. And then obviously if there's any sort of misalignment, and oftentimes we are seeing a vertebral body fracture, and the degree of that fracture and collapse will give you more points. And then finally, do you have disease in the posterior elements going into the pedicles, going into the lamina? So when you kind of add this all up, we end up with these scores. And basically that breaks down to 3 categories. And this will become very obvious as the residents and interns start seeing these patients. You're going to have patients with small tumors with not much symptom. They're going to be in that stable category. You're going to have patients who are in terrible pain, really unable to walk, poor ambulatory status, presenting to the ED. Those are most likely going to be the unstable ones that are going to need some sort of surgery. And then a lot of patients we see in clinic have like sort of subclinical symptoms. We're catching it pretty early, and a lot of those end up in that indeterminate category where, that's where the art of medicine kind of takes hold. You can kind of go either way in terms of stabilization. And so then finally, we get to the systemic component. So you may make a decision on what the patient needs in terms of their neurologic, oncological, and mechanical status. And you kind of have to weigh in how sick they are, what's their predicted survival. You obviously don't want to do a huge surgery with a long recovery time if their predicted survival is going to be pretty poor. And this is where we really do lean on our oncology colleagues who may know the patients much better than we do after following them for years at Fred Hutch to really kind of give us a prediction of what they think their survival will be. Are there various other systemic medications they can switch to that can prolong their survival? And then from our standpoint, there are various survival prediction nomograms that are now becoming in play. And this is one interesting one from the SORG group here that uses a lot of basic lab values and things that you can kind of pick up really easily when you on your first initial evaluation. What's their blood count, hemoglobin, age, how advanced is their disease. And this has shown to have a pretty good prediction in terms of 30, 90, and 1 year probability. So oftentimes we'll go kind of just tie this all together. We often consider the neurologic and oncologic together. And so basically, I'm looking to see, does the patient have low grade versus high grade core compression on that MRI? Versus do they have a radiosensitive or radioresistant histology? So if you have some with a radiosensitive disease such as multiple myeloma or lymphoma, they're going to respond pretty well to conventional radiation and just putting them on steroids. So even if there's high grade core compression, you can get away with avoiding surgery and just proceeding straight to radiation. Whereas for these radio-resistant ones, that's where it gets a little bit more complicated. So if someone has a resistant pathology with low-grade compression, with the advent of stereotactic radiosurgery, our radiation oncology colleagues are really able to contour a plan that gives a high dose to the tumor to overcome that radio resistance, while contouring and sculpting that plan to avoid high dose radiation to the adjacent organs at risk, such as the spinal cord. And so if it's low grade, there's enough separation between the target and the cord, they can deliver stereotactic radiosurgery while avoiding surgery. And then really where our role becomes more obvious is when you have that high grade core compression, they're symptomatic, perhaps weakness, numbness, etc. And then that's where the tumor is just too close to the spinal cord, and they're not going to be able to deliver radiation at a high enough dose. And that's going to either lead to underdosing, which can increase the risk of progression of tumor or recurrence of tumor, or possibly radiation-induced myelitis. So that's where we kind of see our targeted therapies of surgery being used. So we typically would perform separation surgery, and then we would follow them closely with postoperative stereotactic radiosurgery. And so a way I kind of think of it is that if you're kind of put this on two axes, we're talking about the more radio-resistant the tumor is, then the more likely you're going to need one of these more advanced radiation options, such as stereotactic radiosurgery. And then the higher the grade of core compression, that means we're going to need to do some sort of intervention to separate the tumor from the cord. And so that gives you that sort of the continuum from conventional radiation to stereotactic radiosurgery to needing surgery plus stereotactic radiosurgery. And so now this is often called hybrid therapy when you're kind of planning to do both pretty closely together. So here's just a quick example of a patient with multiple myeloma. And again, just to reiterate here, we're having multiple osseous metastases throughout the spine. There's some high-grade core compression in the thoracolumbar spine. You can see the epidural tumor here. The conus is sort of being displaced and compressed. This would be considered high grade. However, multiple myeloma is very radio sensitive. So this patient can go straight to conventional radiation, small dose, 2 weeks of radiation, and that's going to resolve in a short time without needing any sort of surgical intervention for this. So in terms of that radiation, the difference between conventional versus stereotactic, this is probably the biggest advancement in spine met management in the last 20 years. So with conventional, you would have a large beam kind of go through multiple organs. This was low, so we had to give lower doses and multiple fractions to hit the amount you need. But this was very easy to plan. This can be done at any hospital in the country, and you can get large volumes, so like multiple spine segments. So this is sort of a bread and butter. And then with the recent advancements of technology, we have the stereotactic where you can really contour multiple beams coming through at different angles so that the surrounding organs have a much lower dose and much less toxicity. And then those beams of radiation are going to converge into at your target. So you're going to give a super high dose to the tumor target, and then a sharp drop off to the organs at risk. So with this high dose, you're giving an ablative dose. And so you can overcome the radio resistance of some of these solid organ tumors. And so we're giving a much higher biologically effective dose here, often going down to just 1 to 3 fractions, and so you can be done in under a week. And this has really changed the sort of playing field of where we need to intervene. So these are some internal data from Sloan Kettering from my fellowship, where they were doing often a single fraction radiosurgery. And so what we're seeing here is Kaplan-Meier curves of the percent survival here. And what you're seeing is really that it doesn't really matter what the histology is. You're getting control rates in at 3 years in the 90%, because we're really able to overcome the resistance of the various histologies here. And the dose does matter. So here's another internal data chart showing patients in the red getting low dose stereotactic radiosurgery versus high dose in the darker line. And again, much higher survival rates with the higher dose. And so the rate of local failure in tumor at 1 year between low dose versus high dose is about 4.5% difference, and then that's going to increase over time. So you're going to get to local failure rates with the low dose at 15% at 2 years and 20% at 48 months, so 4 years, versus 1 to 2% with the high dose, and these are all statistically significant. And so I think we'll just take a couple slides to talk a little bit about that radiosurgery and sort of how we plan that. And that kind of helps us know what type of surgery we're going to be doing there, and how much of how extensive a resection do you need to do. So from the radiation oncology's perspective, they sort of break down each vertebral body and with its tumor into these sort of classification system. And this is also based off of and adopted from the way we think of primary bone tumors and how we classify where to make our cuts for unblocked resections and whatnot. So basically just a clock system starting with the vertebral body at 1, and then kind of just working your way around the clock. 2 and 6 are going to be the pedicles. 3 and 5 are going to be the transverse process, facet joints, and lamina, and then 4 is going to be your spinous process. And so where a tumor is going to dictate how much radiation you need to give. And so this goes into these sort of consensus guidelines of so GTV is your gross tumor volume, and then the CTV is like your clinical target volume. So you take your GTV. So for example, if you have a tumor that's in any portion of the vertebral body, we assume that's all one marrow space. So you want to extend your radiation to include the entire vertebral body. So that's your CTV. And then as another example, if you have a tumor that's kind of lateralizes in one part of the vertebral body, so say it's kind of creeping towards 1 and 2, into the pedicle. So you would want to include your radiation to the entire vertebral body, and then you're going to extend that into the ipsilateral pedicle and transverse process. So you kind of want to take where the tumor is, presume that entire marrow space is involved. You're going to radiate that, and then you're going to extend that to usually one segment in either direction. And so just to give you, again, some examples, you'll hear these terms from our radiation oncology colleagues. GTV is the gross tumor volume, the CTV, the clinical volume, which is going to be that expansion of the marrow space as we talked about, kind of using that clockwork system. And then the PTV is the planning target volume. So they add a couple of millimeters in addition to that CTV to account for possible minor changes in positioning and inaccuracies in the imaging software. And so when we think about the surgeries that we need to do, we need to really think about where that tumor is and how much of that is getting close to the epidural space, so we can kind of think of what needs to be resected here. And so here's an example of radiation plans based off of the locations of the tumor, just to kind of hone that down. So if you have a small met within the mid vertebral body, you would assume that that entire marrow space is affected with microscopic disease. And so you would want to really target the entire vertebral body in your clinical CTV. clinical targeting volume. And so here's in contrast, if you have that ipsilateral vertebral body and kind of extending to the pedicle, you're going to extend that entire vertebral body, the pedicle, and then the next segment over in the clock, which would be the transverse process and lamina. And then on the bottom here, we have a posterior element disease. So that'd be like section 4. And then you're going to extend that to include both lamina and a little bit of the pedicles here in transverse process. Um, and so there's been a huge evolution as we integrate that stereotactic radiosurgery into our treatment algorithm. So maybe 10, 15 years ago, you would have a patient with a solitary renal cell. This is considered fairly radio resistant. So, 10 years ago, 15 years ago, many spine surgeons would undergo a fairly large en bloc resection here, huge reconstruction, possibly front, back surgery. And these were fun cases, awesome cases, but they're very morbid. We're having operative time in this case report of 15 hours, 5 years of blood loss, multiple transfusions, long hospital stay. And nowadays, with the current paradigms, this patient may not need surgery at all, and they would go in for 1 to 2 days of radiation. Total treatment time would be 20 minutes, no blood loss, and we're getting comparable tumor control, if not better, with 98% control at multiple years out. And so the spinal oncology study group recommends a strong recommendation that radiosurgery should be considered over conventional radiation for solid tumors, especially for radio-resistant histology. And SRS is safe and effective, regardless of the sensitivity of the tumor to conventional radiation therapies. So then, in terms of where do we do surgery if SRS is so good, that really is going to be limited to this area of high grade spinal cord compression in radio-resistant tumors. So what happens in this scenario is that if they don't go for surgery, what the radiation oncology team is going to underdose the tumor that's in the epidural space. And with that underdosing, that's where you're going to see your recurrence and progression of disease because the dose you need to ablate the tumor is higher than what the spinal cord can handle here. And so this idea of like a radiosurgical decompression has been sort of evaluated already, and the resolution of soft tissue disease in the epidural space can take several months. So if you're having someone with subclinical symptoms or just early signs of myelopathy, radiculopathy, they're not going to be able to wait for the months it takes for this tumor to get treated with the radiation. And so they're going to be at risk of myelopathy development that whole time. And then we've had a randomized trial. This would be really important for the residents to understand. This is the Patchel trial from '05 and Lancet study. This really kind of gave us permission to operate on these patients. So this direct decompressive surgical resection for spinal cord compression caused by metastatic cancer. This was a randomized controlled trial, prospectively studied. They looked at solid tumors, high-grade cord compression, myelopathy, just what we're going to see every day in clinic and in the ER. And they randomized patients to surgery plus radiation versus RT alone. And the primary endpoint was ambulatory status, and secondary endpoints was incontinence, pain, medication use, steroids, and survival. And so in this chart here, you can see surgery versus radiation. The darker blue, much better ambulatory status for these patients versus radiation alone. And so here's some data from that trial of the eligibility. And again, yeah, so you had about 50 patients in the radiation group, 50 patients in the surgery group. They were matched well in terms of histologies and their ambulatory status. And so again, time remaining for ambulation was much higher in the surgery decompression group in terms of the number of days as well as the percentage. And then in terms of the secondary outcomes here, radiation and surgery versus radiation alone, everything was significant. So ambulatory status, how long they were staying ambulatory, how many could recover motor function, bowel bladder dysfunction, use of narcotics, and then even survival was significant here. So there's a strong recommendation for patients with high-grade cord compression to undergo, from a solid tumor to undergo surgical decompression stabilization, and then followed by radiation. So then the big question becomes, now we kind of know the indications for when we intervene for surgery. What type of surgery do we do? How big do we go? This is where separation surgery evolved. Now that we have great radiation options, how do we integrate the surgery and radiation together to minimize how big of a surgery do we do? So basically, the separation surgery is really trying to resect the epidural tumor to provide a safe radiation target post-operatively. We don't need to go chasing after every single tumor cell and do a much more morbid surgery because we are going to provide radiation afterwards either way. So it's better to just do a smaller surgery, get them out of Dodge, and then send the patients over to radiation. So typically for separation surgery, we're going to do posterior instrumented stabilization. You're going to do a posterior lateral decompression, which usually involves a laminectomy at the side of the tumor and a little bit higher and lower. So you can find your dural planes. And then once you find your dural planes, you're going to be doing a circumferential thecal decompression by resecting the epidural tumor all the way around. Typically, when we talk to our radiation oncology colleagues, what they want is a few millimeters of gap between the residual tumor and the spinal cord. So here's an example of one of our patients with a preoperative MRI showing a high-grade cord compression where basically the spinal cord is kind of hidden right in here, their circumferential tumor. You can see there's tumor extending way into the vertebral body. So this type of surgery would involve, doing the stabilization, laminectomy, really drilling down this left pedicle, resecting all this epidural tumor. And we don't go chasing off after this whole vertebral body. We're just trying to clear up the dura from the epidural tumor. Typically want to give our radiation colleagues about 3 to 4 millimeters of space between whatever epidural tumor is left and the dura. And so then we often get post-operative myelograms in the inpatient side or in a special type of MRI that they use for radiation planning. And what we want to see is reconstitution of the spinal cord and the epidural space here. And so you can see again, that cord has kind of moved back to the center and all the epidural tumor around it has been removed. But we haven't really done a huge corpectomy here. So it's a much less morbid procedure and involves less hardware and needing cages and whatnot. So again, so this combination of tumor of separation surgery plus postoperative radiation has shown to have improved tumor control. So this combination here, the high dose, the hypofractionated, so giving 3 to 4 fractions is in the red line, and this has been borne out in multiple studies in multiple centers to have the best kind of outcome here. So hypofractionated high dose has a 1-year progression of only 4% versus that low dose, which will go up to 20%. And for some odd reason, when we give a single dose, really high dose, that wasn't the best option here, and that led to about a 9% failure rate. And so a lot of centers have moved for this giving a high dose in about 3 to 5 fractions as kind of the sweet spot. Again, so the recommendation from AO Spine is that clinicians should surgically debulk high-grade epidural disease before stereotactic radiosurgery to optimize local control. And this combination is safe and effective, especially for radioresistant tumors. And so then another indication for surgery would be for mechanical reasons. So you may have a patient that has a radiosensitive tumor or something that's not super high grade cord compression, but they may have really bad symptoms from their spinal instability. And this is where it's really important for us to communicate with our medical oncology colleagues because they may say, oh, we have a new drug to try that's really, penetrates through the bone, but that's not going to treat their underlying fracture. And a lot of times patients don't understand that as well, that they think, oh, okay, we got a new drug and it's been shown to be really responsive. It shrinks the tumor away. We're going to go to radiation. Why do I need surgery? And so when we're talking about mechanical stability, we're really talking about tumor instability that's affecting the bone quality and basically the difference here is really going to be, do they have pain that's from the cancer itself versus a movement related? And so steroids will improve your biological pain, but it's not going to really help with an unstable fracture. And you're going to have to figure out where that tumor is and what kind of symptoms that they may be contributing to. So, for example, if you have a tumor at the occipital cervical junction, they're going to have problems moving their head, subaxial spine. There's going to be issues with flexion, extension, thoracic. A lot of these patients will say they have hard time sort of extending, laying flat, so they're sleeping on reclining chairs. And then a lot of patients with the lumbar, they may not have cord compression because we're below the level of the conus, but they may have really bad radiculopathy when they're kind of standing, bending, twisting, that they really may be sort of crushing their exiting nerve roots because of the fractures. And again, so this is where that SIN score comes into play. We kind of calculate this for every single consult we see to kind of guide us into how aggressive we need to be with stabilization. The treatment options for stabilization may be for a small, low-level SINs. That's just a symptomatic compression fracture would be something called cement augmentation involving a vertebroplasty or kyphoplasty. This is often done by our interventional radiology colleagues, and we sometimes do this on the inpatient side as well. And then in terms of the next trial, this is called the CAFE trial. So if you talk to a lot of our medicine colleagues, they may say, oh, we've read that kyphoplasties don't work well for fractures, and it's mostly related to traumatic fractures or osteoporotic fractures, whereas in the cancer world, we do have evidence, level 1 evidence that shows that it is safe and effective. So this was one big trial here, balloon kyphoplasty versus non-surgical management for painful pathologic fractures, randomized controlled trial. Again, non-surgical management is going to be wearing a back brace, putting them on pain meds. It has limited effectiveness. And that type of severe back pain can lead to poor outcomes if they're not managed well, and also if they undergo big open surgeries for spine stabilization with screws, they may have poor outcomes from that as well. So this is where there's a big role for minimally invasive options such as the kyphoplasty, which and prior studies to this one, retrospective studies show that it reduces pain, restores vertebral body height, and improves quality of life and function. So in this randomized trial, they had about 400 patients that were first assessed for if they were eligible, and it kind of came down to about 60 to 70 patients who were randomized. And again, conservative management included pain meds, bed rest, bracing, PT, and then bone fortification with calcium, vitamin D. Again, the groups were well matched. And so here you have your quality of life outcomes and disability. And so basically, the red is the baseline numbers, whereas blue is 1 month after the procedure. This first column here is the groups that got cement augmentation, so significant reduction, versus the control group that had non-interventions. And then this is their performance scale. And again, the KPS improved after kyphoplasties were stable in patients who did not undergo an intervention. And then various other disability and quality of life indices, such as the SF-36. Same thing all across the board, essentially here. And here's the reduced activity days again. So they were much more active with the once they received their treatment of their fracture. And then this was followed out in subsequent studies for up to 12 months. Again, and it was durable treatment. So here's the outcomes. Red is the kyphoplastic group, whereas the blue was the non-op. And then obviously there was a high crossover if you continue to follow these patients after the trial was over. And again, one limitation for this is this trial was sponsored by the company that provided the cement and the balloons. They contributed to the study design, and then they allowed the crossover to happen after the first month. So the long-term analysis is not randomized, and patients were, not blinded. There's no sham procedure here. And so in conclusion from that trial, at 1 month, in comparison to non-surgical management, cancer patients with symptomatic pathological fractures, if they're treated with a kyphoplasty, they had statistically and clinically significant improvement in functional status at 1 month, reduction in back pain, improvement in quality of life measures, and less pain medication use. And these were generally maintained at 1 year follow-up. That kyphoplasty is a great option. And then we go to, if you have a higher sin score, you may need percutaneous fixation. And then if you have something that's really, really unstable, a high sin score, especially upper cervical spine where we don't have great perc options, then you would need our traditional bread and butter open fusion surgery. And then, of course, we went back to the NOM scale looking at the systemic. So you may want to do surgery and you kind of have to weigh that in with how sick that patient is. So there's various frailty indices that we use to kind of predict how well the patient's going to thrive. This is where we really lean on our collaborators with our oncologists to kind of guide us in how aggressive to be. And it's a moving target. Every month, every year, there's going to be new systemic medications that really kind of change the course of survival. Here's an example, I believe, with patients with melanoma, immunotherapy, showing a huge change in survival with the new medications. And this has really kind of changed the landscape for melanoma management and really kind of changed what their survival prediction is going to be. So the onus is on us to really kind of keep up with that oncology literature because what may have been considered a poor prognosis last year may have be completely different in your next patient. And so for the systemic patients, again, we're trying to deal with patients who are very medically frail. So it's important to kind of optimize them for the OR. So there's a coordination with oncologists, getting pulmonary functional testing, cardiac testing. We often get duplexes to rule out DVTs for all of our patients that come in because we know that they have all three of the Verkow's triad. They're going to be immobile, they have cancer, they're pretty sick, and they have these fractures. So patients who are non-ambulatory from core compression fractures, we've shown that there's about 25% of them, 24% of them have an undiagnosed DVT. That's going to change what we can do in terms of anticoagulation. And then the standard ER workup is going to be get an MRI total spine to rule out tandem lesions, possibly PET scans, CAT scans, and then obviously just standard lab work plus oncology lab work. And then just for the last 5, 10 minutes, we'll just go quickly into sort of the modern therapies, what we're doing in terms of surgical advancements. So I think the big interest for me in trying to expand what we can provide to our patients is really minimally invasive surgery. So MIS has been done extensively for degenerative spine, for trauma, for deformity, and the benefits are clear. There's less tissue disruption, there's smaller incisions, less operating time, shorter hospital stay, and less pain meds used because of the less trauma. And this seems to be a great fit for our cancer patients who are medically frail, they have poor wound healing, significant preoperative opioid usage because of their cancer. And then any type of big surgery we do requires a pause in their chemo. So if we can really minimize the morbidity from the surgery, we can really maximize their treatments options and kind of get them back to their systemic treatments and their radiation. So just trying to really minimize our disruption. And so with the MIS techniques, a lot of this is going to be depending on enabling technology. Here at UW and Harborview, we have great options here in terms of the technology with image guided navigation, et cetera. So the MIS techniques that we employ on a daily basis is going to be for the stabilization is percutaneous fixation with navigation, using shorter constructs by cement augmenting our screws, and then the kyphoplasties and that we discussed. And then even with our doing our separation surgeries, we're trying to minimize that by employing the decompression through minimally invasive tractors, such as the tubes or expandable retractors. And then we've been kind of trying to really investigate, can we use endoscopy or robotics for this? So again, for the vertebral augmentation, we already discussed that cafe trial. Here's just a little figure showing that. Then the percutaneous fixation is kind of the bread and butter right now for our practice, and this really has been improved with the aid of navigation. So we're making small stab incision for each screw at each level, and then we can administer cement through the screws, which have penetrations at the tip, to improve the bony purchase. And then this has allowed us to really limit how long of a construct we can do because we can overcome the inherent weakness of the bone in these cancer patients. And again, so we're using percutaneous fixation with navigation as our enabling technology. So a lot of these patients, and because of their poor bone quality, it's really hard to visualize on just standard 2D fluoroscopy, just because their bone density is pretty poor. And so with using the technologies we have, such as O-arm navigation with the Medtronic Stealth, or we have a Globus robot now, We can really plan small incisions from the skin level and then cannulating the pedicles with the navigation. So every single step. And by doing this, we're really avoiding multiple sort of cannulations, revisions, and with that, then we can reduce the risk of cement extravasation by not having too many different tracks going through the pedicles. And so here's just a little model again showing you the screws, and then we can inject the cement. So you get a little cloud of cement at the tip, and that should prevent pullout. And with this, yeah. And then with this, we can sort of reduce the construct from a multi-level construct to a really small construct involving the screws. Here's just a quick fluoro in the OR showing screws above and below with a kyphoplasty or vertebroplasty needle in the middle at the tumor level, and just giving the big clouds there and the small construct there. And then with the MIS techniques, bringing down ports just like we do for our tubular cases and doing a really small decompression. So with that, you really need to know the goal of your surgery because you're not going to have a big open field. And so there is an algorithm that we use to figure out how much of a decompression do you need to do. So you have a fracture, you have a decompression that's needed. So you'll do either mini open or in the lumbar spine. If you just have radiculopathy from a unilateral disease, you may get away with just a unilateral laminotomy facetectomy. And so we often use this algorithm to kind of decide on how small we can go. So as a case example, we have a patient with a non-small lung cancer. They had an L3 tumor causing left-sided radiculopathy from tumor that was kind of extending from the vertebral body into the epidural space and kind of crowding that pedicle and the exiting nerve root. So yes, they had mechanical radiculopathy. We do need a decompression, and this is where you would do percutaneous screws and just a unilateral facetectomy and really free up that nerve root. And here's the post-op just to show you what we're talking about, how small you can go here. So this is a patient that gets discharged on day 2, and then they get post-op radiation a week or two later because they have such small incisions that we're not worried about wound healing problems. So again, so this is the preoperative tumor. We got a CT myelogram while they're in the hospital. You can see a really small laminotomy, really freed up the nerve root and the epidural tumor, really small foraminoplasty essentially, and then they can go straight to radiation for it. This has been validated in patients' PRO studies that they're having significant improvement in back pain and disease and their ambulatory function with these small procedures. And again, so MIS provides safe and effective stabilization and decompression for patients and it reduces the risk of postoperative wound complications. And here's something that's really exciting. Again, this was done by me with Dr. Hofstetter. So I'm really happy that I had the opportunity to work here because obviously the great mentorship with Dr. Ellenbogen and everyone at Montligan, especially with Dr. Hofstetter, so we can really kind of push the borders, the boundaries. So as you guys all know, he's a world expert in endoscopic spine surgery, and then we're trying to adopt that. Can we bring those benefits of endoscopic surgery from the degen pathology to tumors? So this is a patient that we did maybe 2 years ago, and we're still following him. So he's got 2 years of local control now. So 32-year-old metastatic thymoma. He had a lung plaque and he needed to undergo proton radiation, and they wanted to avoid hardware, which would kind of mess up their radiation plans. So there's just a lung plaque here, and it's starting to creep into the epidural space. Pretty low grade, but this was a perfect test example for us to see if we can push the borders. So all they really wanted was for us to kind of free up this foramen. With the proton radiation, they can't contour it as nicely as with the stereotactic radiosurgery. So they wanted us to really completely remove the epidural component of this. Here's a few screenshots, and I think Dr. Hofstadter has a video that we're preparing for publication. So here's a transforaminal route, putting the first needles and dilators over that, going in and really doing a big foraminoplasty with the reamers. And then once we get there, we always take a shot with our instruments to make sure that we're wrapped around the pedicle as we kind of know where we're at. Here's the intraoperative video picture showing above here is basically the remaining bone through that transfer route. Deep to us is going to be the spinal cord, and this all fuzzy stuff is the metastatic lesion that's kind of creeping into the epidural space. So Dr. Hofstadter and I, we just kind of removed this amount here until we could see a nice, clear spinal cord pulsating nicely. And then the post-op MRI. So again, preoperatively, here was that epidural tumor that they want us to remove. And then here's the post-operative MRI that they use for radiation planning, where that tumor has been successfully resected. So again, this was like a less than a 2-hour surgery, outpatient separation surgery. The incision was so small that we couldn't even see it when he came back for follow-up. And this patient went straight to proton radiation about a week later after this MRI. And we're still following him 2 years out. Good local control here, never needed any bigger surgery. So again, MIS provides safe and effective stabilization. And then so as we come to the end, the quick conclusion. So the NOOMS provides an evidence-based decision framework for integrating radiation rationally with our surgical treatment options for metastatic spine tumors. The role of surgery is really limited to separation surgery to create a safe radiation target. And we're ultimately trying to preserve neurological function and then stabilizing the spine if they have a mechanical instability as defined by the SIN score. And then using minimally invasive techniques with enabling technology can help us adopt these surgical goals while minimizing disruptions to systemic therapies. And then the last few slides is just our internal data from the last few years. We've had a lot of med students rotate through, especially for they have like this triple I period during the summers between first and second year. So they've been able to help us collect our data for the first 2 years. And this is an ongoing project every year with as we get more and more med students. So here's like the first 115 patients in my first 2 years here. This is multiple surgeons between Montlake and Harborview. So we're having pretty good control rates, local tumor over 90 patients versus 114. What we're seeing is there is a big difference between elective and emergent, and also as predictors of survival is going to be the postoperative DISCI score. So here's a time to death based off of if a patient has elective surgery, which is the red, and then versus emergent surgery in blue. So this is really harks into how critical it is to really diagnose these patients and provide early intervention. I think a lot of, as we all know, we have really big ERs, both hospitals, and we're providing care for really sick, complex patients. And so these patients that are going under emergent surgery, we're really catching them really late into their cancer diagnosis. So there's a stark difference between those patients that we catch early on and undergo elective surgery. And then I think what's really important also is, how good of a surgery do we do? So this is survival based off of their post-op epidural cord compression score, the Bilski score. So, you may go in with a grade 3 and, you have all the best intentions to do a big surgery, but you may not be able to achieve that. Either they're too sick or it's stuck, the tumor's too stuck to the dura, it's too bloody, too vascular, and so you may not be able to achieve that successful decompression. So what we can see here is that patients who have no cord compression at the end of the surgery on their post-op imaging, this is the red, they have much significantly longer survival. And just as we go down to like a low grade versus a high grade, there's a huge difference in survival here. And then finally, we looked at social deprivation indices. So this is a big component of social determinants of health. This one is easy to calculate for patients because there are national surveys that are done based off of the patient's zip code. So this SDI is a component measure of various things that are proxy for, social determinants of health. And so we looked at all those 114 patients, what their SDI score is. So a high score is bad, as in they're having poor access to healthcare. And what we're seeing is that patients with a higher score, which is on the Y scale, they're having statistically more presentation with high grade cord compression compared to a lower grade. And so I think what's the big key here is that a lot of these patients with the poor social determinants of health, they're going to be coming more advanced disease. They're probably going to be coming in with emergent cases versus elective cases. So we are sort of responsible for providing care to these patients of varying walks of life. And what we can show is that if we can get that tumor burden down to a low grade of cord compression, we can kind of overcome that that risk of disease and really get them to a better survival. So the surgery that we do and the quality of surgery we do makes a huge difference here. I think that's it for our slides. Thank you guys.
Thank you. That was great. Really wonderful and new, and really taking the program forward. I loved your that case with the minimally invasive approach. So it keeps evolving. Any questions? A really beautiful presentation and great summation of the progress that we're making. Anybody? Any comments? Any questions for Anu? I think it was so good that you answered all the questions. Wait, Jerome Graber. There you go. We found you. Okay, Jerome, go.
Yeah, this is not an intentional plant, but I know Dr. Amin and I have talked about it before. A lot of the foundational studies of this that were done over 20 years ago. And obviously, oncology care and cancer patient outcomes have like radically and dramatically changed since these foundational studies. So, do you think for any specific cancer types or systemic therapy types, we need to reevaluate some of the original studies?
Yeah, that's a great question. I know there's a few studies that we've participated in where, our dogma for the last 10, 15 years has been, oh, this stereotactic radiosurgery is kind of ablates everything and it doesn't really matter what histology you have. And so now we're getting into the really nitty-gritty details, and there is graded response based off of each lung pathology or between each histology. So even though, yes, we're achieving 90% of the control rates, there is a huge difference between colorectal cancer and non-small cancer. So now we're kind of going back as we accumulate more and more data to like histology specific, and there are clear differences. And so we're going histology specific now that we have enough data. And yes, and if you look at like in the last 20 years, I know Dr. Bilski has published a new paper looking at the last 20 years, and beyond, while the surgical techniques have made mild improvements, the patient survival are significantly different now in comparison to 20 years ago, which
Thanks to
is
the
attributed to
systemic
radiation.
treatment.
Yep.
Yeah,
Yep.
that's a great point. Randy, you have a question? Thanks, Jerome. Randy, you have a question too?
Yeah. I think I mean, interesting bit about the emergent versus non-emergent. I mean, clearly you hate to see the patient come in who just went plegic and is sick and has a relatively bad disease, and now you're trying to figure out what to do and what you can do and what you should do. And then it comes to prognosis, which is a big part of this. You don't want someone to die in a hospital trying to get over the surgery you did, try to make them better, when the likelihood of making them better isn't great and they'll never be perfect. So then, I mean, we used to end up going to like the Tokuhashi score, which was a holder, but not very satisfying. I mean, and then you'd call oncology, and by definition, an oncologist has to be an optimist, like a trauma surgeon. You're either an optimist or you can't do the job. And now you have these newer nomograms, but a nomogram is never quite like an individual evaluation. And I'm just wondering where it sits, because especially in those emergent patients, making that decision whether or not to emergently do a big whack has there's a lot of importance to the prognosis. And how comfortable are you with these nomograms, and how are you dealing with on oncology often saying, well, we don't really want to tell you a short number for survival?
Yeah, great point, Dr. Chestnut. As you can imagine, we're dealing with that on every patient that comes in through the ED. It can be pretty frustrating and complicates what our plan is going to be. So I think the first thing is, how often do we actually use the nomogram? Not that often, because of the various variables you need to kind of calculate, and can you really do that in a reasonable time span? But I think we do kind of lean on our oncology colleagues a lot. So one of the big things we did was we created a spine tumor board that's separate from the neuro-oncology tumor board. And so we're meeting weekly, discussing the inpatient consults, and specifically, we're having a radonc attend, and we try to pull in the mid-oncs that are responsible for those patients to kind of give us some idea of, is there a different medication that you can try next? If you don't have any other medication to try, then we're going to probably offer a much smaller procedure, or avoid surgery altogether. And
Got it.
then Another thing we're trying to do is something called a cord compression protocol through the ED. So basically having like a mini tumor board where the ER will consult the spine on call, radonc on call, and oncology on call. So we can kind of come up with a coordinated plan while they're in the ER so that we're not wasting a lot of time with patients kind of going back and forth with multiple consults.
Well, that seems like a good plan. That's great, because that's where the conflict comes.
Yeah.
Well, thanks. That was wonderful and really great and tremendous work you're doing, and we're so thrilled to have you here. It's been 5 years, right?
Yep. Yep.
Amazing difference you've made. So thank you for all the hard work and all your partners, all your spine partners who have contributed to this shift in outcome and care. All
Thank you so much.